So yeah, the second talk is going to be about spinal instability, stabilization, and semantic augmentation. And I'll focus a little bit on the semantic augmentation as a follow-up to the talk we just have seen. So spinal instability, we used to always think about the 2-column, the 3-column, the 6-column, all coming from the trauma ward. And the question was, initially, the application of spinal instability was related to those models of Denise and Costwick. And those models have been adopted initially from that models to spine oncology. But then we realized that with spine oncology, these type of instabilities are really not immediate. They are glacial. It means that the instability of patients with spine tumor typically occur over time, where the vertebrae start developing a small fracture, which evolves into a newer fracture, bigger fracture. And so the thought was that these models that have applied to trauma, for example, may not be applied to a patient with spine oncology. When it comes to spinal instability, one thing that is important to realize that we as spine surgeons who are dealing with doing surgeries on spine, we can just look at an image many times and we can say, without really getting into all the philosophical arguments about 2-column, 3 columns, you look at this picture and you don't need to be a spine surgeon to say this spine is unstable. So a lot of what we came about and what I'm going to talk about is really the designation of spinal instability on patient with spine oncology may not necessarily was something that had to be addressed with spine surgeons, but more had to be addressed with our colleagues, the radiation oncologists, the medical oncologists, who see a lot of these patients, as were alluded before, and their thought is, when should we refer these patients to the spine surgeons? Is the spine stable or unstable? So a lot of this stuff, and especially the spine instability neoplastic score, was about developed for our colleagues to look at a film and then decide whether this is something that needs to be referred by looking at the films. It could be a radiologist, it could be a medical oncologist who gets a report about a fracture, it could be a radiation oncologist. Does any of these cases needs to be referred immediately to a spine surgeon? And the key question always that comes about is whether the spine is stable or unstable. And so you can see right here that the spine oncology study group have got together and develop a novel classification system for spinal instability on patients with spine tumors. And this is a very easy classification system to use. We have a lot of our residents, a lot of our fellow walk with this thing, and then when they evaluate a patient, they can immediately assess the level of instability. And ultimately, what it is that you add the points according to this particular table. And if you get 0 to 6 points, the spine is stable. If you get 7 to 12 points, the spine is potentially unstable. And if you get 13 to 18 points, then the spine is unstable. That doesn't mean necessarily that patients who have potentially unstable spine need surgery. This scale has nothing to do with whether patient needs surgery or not. It's purely say whether the spine is stable or unstable. So this classification is not an indication for surgery. And if you look at this table, and I want to spend just a few more minutes on it, you can see what are the things that we put emphasis on. So if you look at the amount of 3 points that the patient gets, the ones that get the highest amount of points is number 1, location and the junctional areas. So 3 points, if there's any fracture between the occiput and C2, C7 to T2, T11 to L1, L5 to S1, the junctional areas where we believe there's much more likelihood of a fracture. If there's a fracture there, the patient gets immediately 3 points. So location is on the top of the list, and junctional areas are on the top of the list when it comes to getting points. The second thing, which is really also very important, is what we call mechanical pain, or pain that gets better when the patient lying down. And if you look at that, you see immediately that mechanical pain is very critical to assess stability or potentially unstable spine. If the patient has mechanical pain, the patient gets immediately 3 points. If he has no or occasional pain, but not mechanical, and sometimes it's biological pain related to the tumor within the bone, it drops immediately to 1 point. So right there, if you have a patient who have junctional fracture with mechanical movement, he already, that particular patient already is going to have 6 points. So these are really the top two key elements of the tables. The other ones are getting less. The next one is really whether the bone is lytic or whether it's blastic. Clearly, if it's blastic, then 0 points for that. If the bone is lytic, you get 2 points. And then you get into the most important thing, which is the radiographic alignment. Because if there is evidence of subluxation or translation, for that, you get 4 points, which is the maximum amount of points that you get on this particular table. The other points that patients get is how much of the vertebra is being broken. So if there's more than 50% collapse, it's 3 points. If it's less than 50%, then it's 2 points. And then we get down to the bottom, which is whether there is a posterolateral involvement of the spine elements, whether the facets, the pedicles, which are critical in spinal instability, are involved. And if there is tumor that involves both facets, both pedicles, then bilateral involvement gets 3 points, unilateral gets 1 point, and none gets 0 points. So you can see how these are the things that we emphasize with this particular table, and that by adding those points that allow us to kind of determine stability, potentially instability, and unstable. So here's an example. Without thinking about this table, you look at it and you say, well, we got a patient, he's 66, he has lung cancer, he has a fracture there, no canal compromise, but there is a fracture there at L3. Is this stable or unstable? And just imagine yourself at this point not being a spine surgeon. You get a radiologist that's getting this MRI, he's seeing it for the first time. You get a radiation oncologist or a medical oncologist, and they don't know whether this is something that needs to be referred, this is something that they can be watched. How stable is the spine? These are the guys that this table gets, this table helps. So this patient have lower back pain, it works with activity. So right there, it tells you that this is mechanical symptomatology. The patient otherwise is neurologically intact. And so if you take at this point and you look at the location, this is going to be 2 because it's a mobile spine between L2 to L4. The patient does have mechanical pain, so he gets 3 for that. And the lesion, you can see on the CAT scan that it's lytic, so he gets 2 for that. There is no subluxation, there's no deformity of the spine, so there's 0 point for alignment. The vertebral body is less than 50% collapse, so there's 2 points. And then when it comes to posterolateral involvement, there's 0 points. And if you add those points, you get 9 points, which actually points to the fact that this spine is potentially unstable. Does it mean that this patient needs surgery? Not necessarily. It just points to the fact that this spine is potentially unstable. So I think that if there's one tool that you want to take out of this talk, is that this is a very useful, functional way of an immediate assessment of stability of patients with metastatic disease to the spine. I'm going to talk a little bit about stabilization. I'm not going to talk about it too much. The indication for stabilization, once you get these MRIs with instability, is again, whether you want to change the prognosis, whether you want to fix the instability, whether you want to fix the neurological compromise, or whether the patient has significant amount of mechanical back pain symptomatology. We talked a little bit about unblocked resection for primary bone tumors. I'm not going to spend too much on that. But ultimately, these are the 4 tools that we have to fix these fractures: the intralesional vertebrectomy, the unblocked resection, stereotactic radiosurgery could be an option. And then as I'm going to talk a little bit about cement augmentation with the vertebroplasty, kyphoplasty, this is just an illustration for intralesional resection. This is the most common surgery that we do, where you're going in intralesionally, you take the vertebral body out, and then you can reconstruct it once the vertebrae is out, and you get a nice decompression of the thecal sac. You can then fill up that space with whatever instrumentation that you typically comfortable using. And then once the space has been filled up, in this particular case, I chose to use carbon fiber cage, then you can instrument it and you restore the mechanical stability of the spine. And these are some of the x-rays. Sometimes you don't use carbon fiber or PEEK, you can use titanium cages, and they pretty much function in the same way as a gap filler and restoring stabilization. Beyond the cages that are being used for these, cement injection is a very powerful tool to be used for helping with this mechanical stability, with helping with pain alleviation. I've done several comprehensive reviews of patients, and as I mentioned in our lab, vertebroplasty and kyphoplasty are the main ways of doing this. Vertebroplasty is direct injection of the cement into the vertebral body, and kyphoplasty is a balloon that's being placed into the vertebral body. There is some potential correction of the deformity at that site. The spine jack that was mentioned is working on the same principle of creating to be able to correct some of the deformity that's being created by the fracture. And you can see some of the example here of how this works. Clearly, with vertebroplasty, the fracture stays as is. All that is being done is you inject the cement into the vertebral body. There's no, or could be some minimal correction of the deformity just by the patient's position on the bed. But unlike kyphoplasty, where there's some correction. I want to talk a little bit about what I think is the most critical part about cement injection. And the most critical part about the procedure is not the cement injection. The most critical part about the procedure is placing the needle right through the pedicle and not putting it into the canal. I think that's critical, number one, to make sure that when you put the needle in, that you respect the medial wall of the pedicle as you're taking the needle through the spot where the spinal canal is, where the spinal cord is, and making sure that the needle go to the pedicle and not going to medial or to lateral. So critical evaluation of the pedicle, and you'll see it in the lab, is very important to make sure that you're actually putting the needle very, very accurately. And there are two techniques of doing it. This is the technique that I do. So when I put the needle through the pedicle, I actually do it in an oblique view, and that's an unusual view for most spine surgeons doing minimally invasive. It's a bullseye view where you put the needle right through the pedicle, and so the needle, vertebroplasty needle, goes right along the track of the pedicle. I use an oblique view where the spinous process actually hugs the contralateral pedicle, and by doing that, that allows me to get that needle very medial in the vertebral body to the point that rarely do I need to put two needles. So if you can get that needle into the midline of the vertebral body or even cross midline on an AP by injecting the contralateral cement and then you pull the needle out, you can actually fill up both sides of the vertebral body with one needle injection. And the reason why I like to do it is because in a lot of my cases, there's 2, 3, sometimes 4, 5, 6 vertebrae that are broken. And if you start putting bilateral needles at every single vertebrae, you start having needles hitting each other. The amount of radiation exposure is huge. And so I like the oblique technique because that allows me to get the needle far across midline on an AP and allow me to fill up both sides. This is, and the critical aspect about it is, again, respecting the medial wall so that by the time you reach the medial wall of the pedicle, you're already in the vertebral body and you pass the danger zone of breaching the pedicle and putting the needle into the canal. This is how most surgeons put vertebroplasties. This is the bullseye technique. And that's how surgeons comfortable putting these needles in because that's how minimally invasive screws are being placed in. That's typically not the way I use it, because that necessitates putting 2 vertebroplasty needles through the pedicle, because that needle is going to be unilateral on that one side, and as such, it's going to be very difficult to fill up the cement on the contralateral side. So I go back to the fact that I use this technique where it's oblique, which allows me to get that needle far across midline on an AP and allow me to fill up the entire vertebra through a unilateral injection. Here's an ophthalmologist who had multiple myeloma. Initially developed a T11, L1, L2 fracture, and within 2 weeks after that, he developed L3, L4, L5 fractures. So you can literally see from T11 down to L5, all the vertebrae are broken except T12. And again, this patient was bedridden, unable to get out of bed. You can see the CAT scan with, multitude of these fractures. And so you can see again right here where through a unilateral placements of needles, sometimes we do bilateral, again, depends on where the needle ends up. Sometimes it's difficult to put those needles in very collapsed vertebrae because the width of the vertebrae is the height of the width of the needle sometimes is the height of the vertebrae. If you look at L2, for example, the height of the vertebrae there is the width of the needle. So you got to be very careful as you put those needles right through very fractured vertebrae. And you can see some of the examples right here, where you got, I think somebody has the speakers on. But you can see the intraoperative pictures where the cement is being injected. Another powerful way of using vertebroplasty is adjacent level mets. You can see a patient here that underwent thoracic fixation with a transpedicular vertebrectomy. We develop a met at the level below, for which we supplemented with cement at the bottom of the construct. Sometimes you have patients that transfer that already had instrumentation. This is a little bit more tricky, where you have to, instead of putting this patient through removal of rods and all that kind of stuff, you figure out a way to get that vertebroplasty needles around the rods, where sometimes it's difficult to visualize the vertebrae or the pedicle in order to supplement the anterior columns. And when there was no cannulated screws, what I used to do many times is I used to do vertebroplasty and then follow the vertebroplasty quickly with screws placements right into the cement itself. And you can see right here with all this is not cannulated screws. So there is a way to put cement into the vertebral body as long as you're quick about placement of the screws. And this is a case report that we just published, that even areas that you think you may not be able to access with cement. This is a technical note that we have described for the patient who needed a C2 transoral cement injection. And you can see right here that typically with fracture like this at C2, we ended up doing an OC fusion, but through a transoral approach, you can inject cement into the C2 vertebrae and spare this type of surgery where you do an OC fusion. The Society of Interventional Radiology have had significant guidelines about when not to do it. There's a lot of specific complication related to vertebroplasties when it comes to these are the things that can happen. This is one of those, quote, contraindication, where when you have severe collapse or fractures or bone in the canal, to not to do it. This is a situation where we looked at very carefully. Sometimes you can't put cement because the back wall is so eroded, and there's a high likelihood of cement leakage into the canal because the back wall is missing. And the question that we looked at is whether you can refute some of those contraindications, because a lot of these patients cannot go through big surgeries or vertebrectomies. And so we start pushing some of the limits on the cement. And it started with this particular case where we had a 60-year-old with thymic carcinoma, which meets some of the criteria of not to do cement, with bone in the canal, severe collapse. The patient could not go through a vertebrectomy since she had constrictive malignant pericardial effusion, so she was not a surgical candidate. And so we ended up doing vertebroplasty here, ended up published as a case report in the Journal of Spinal Disorder and Technique. And you can see the cement right there in the vertebral body, and that patient was able to get out of bed with significant pain relief. We then start looking at a lot of these cases, and we publish our data when it comes to the fact that a lot of these cases, especially in patients with cancer that are unable to get out of bed, there is an option to refute some of those proposed contraindications. So I want to end up that vertebroplasty seems to be a straightforward, quick, easy procedure, but there could be a lot of issues that can be evolved of it, especially when it comes to needle placement. As I said, the fastest way to turn a dove into an albatross is to stick a needle into it. Complications can occur. Here is some example of cement in the canal that leaked into the canal. This is a patient who had 2-level vertebroplasty, and you can see cement, in essence, encasing the thecal sac all along, up and down the thecal sac. Sometimes you can get a particle of cement in the brain, in the lungs. This is a case where cement was injected into a vertebral body, and before you know it, there was a break through the back wall, so the cement went into the canal. I think that it's very critical to be very careful about analysis of the candidacy of patient for the cement injection. Cement can also be used in other ways. We talked about all these cages, but this, my common practice is in a lot of these transpedicular vertebrectomies. Once the vertebrae is taken away, we can put a block of cement there, and we don't necessarily need to put a cage when it comes to saving cost and things like that. So cement works very well instead of any cages for reconstruction of the anterior columns. And now what we're doing in our lab, in our spinal oncology cancer engineering program, we start looking at personalized models, 3D printing. We're trying to predict which vertebrae is going to break, especially when it comes to higher level of stereotactic radiosurgery. We're looking at animal models, and ultimately, instead of doing something like this, where we're getting all these cages around, we start looking at 3D printing to replace vertebrae, or even secrectomies when it comes to being able to reconstruct the pieces that actually we are taking out. We're looking at other models when it comes to does it actually needs to be cylindrical, or whether it can be different shape that can restore just as much mechanical stability to the spine. So we are looking at vertebral fractures model. We quantify risks of patient with the cancer patient of how much of the bone needs to be involved before those fractures occur. The outcome that we're looking at is enhancing patient selection and help identify patient for vertebral compression fracture risks, better understanding the effect of radiation on the vertebral body strength. We clearly know that radiation, especially stereotactic radiosurgery, can induce fractures, and then evaluate the overall effect of separation surgery with vertebroplasty instead of taking the whole vertebra as a whole. So in conclusion, the management is challenging. It is important to restore and protect the neurological function. It does help with pain, and it can have significant impact on the quality of patients' lives. Thank you.
That was terrific, Udi. Always great to see your perspective and your wisdom, especially with some of these, I think the palliative cases that you showed really kind of demonstrate how far we've come and how even just through, stabilizing 1 or 2 levels can really help a cancer patient.
Yeah. Yeah, vertebroplasty is a very powerful tool. We have a pretty significant patient population with multiple myeloma, and as you all know, these are typically patients that present with multitude of fractures. We also have a very robust program with our stereotactic radiosurgery program, and we're really looking at the issues of fractures, stereotactic radiosurgery-induced fractures, and when to put cement prophylactically. So, we always have some discussions among ourselves, is where is the role for prophylactic vertebroplasty on patient, and I know Mark Bilski have looked at it a lot, and they have a lot of experience with that. But I think that beyond, there is a fracture there, so we're going to put cement in there, there can be a role for prophylactic cement injection with the evolution and the rapid progress in the stereotactic radiosurgery field.
Yeah, that's interesting, Udi, because I agree with you. I think a lot of times what we do is we put in cement to keep those vertebral bodies from collapsing, retropulsing. So this whole notion, and I still remember all these papers that people wrote on. It's a very complicated issue, and I think it's depending on the patient and what they're facing. I think, like you said, it's very personalized treatment. And although they might have continued pain or other problems and their cancer burden and other complicating factors, it'll keep them from having progressive neurologic problems and avoiding a bigger surgery. So these are great points you bring up.
Yeah, I think the key, and I'm curious to know what Mark will think about talking about that, is I have some very healthy conversation with my radiation oncology colleagues, and Duke is going to talk about that, where when we do radiosurgery and a patient develop a fracture likely related to the radiosurgery, start having pain, we're going in and we do cement injection. If a patient has a fracture already and he needs radiosurgery, we'll go ahead and do the cement and the patient will follow with radiosurgery. The bigger question for me is, if a patient does not have a fracture, there's no fracture there, but has biological pain related to the metastases at that particular level, is there a role to start doing prophylactic cement injection in non-fractured vertebrae because of the risk, the 30% risk that its vertebra is going to break? So I think, and I don't know the answer for that. My radiation oncologist may be pushing me further to say, listen, we are worried about these fractures. You should start thinking about this prophylactic cement, even if they are not broken. And I put some pushback on this because I like to actually see a fracture there before I go ahead and I put the cement in there. Because once we get into this prophylactic injection on non-fractured vertebrae, where is it going to end? But I'm not sure I have the right answer for that.
Yeah, those are great questions, Udi. So thank you again for all your participation and efforts, and we look forward to seeing you here in person next year.
Yeah, hopefully everything is free. We're not allowed to travel yet. It's crazy.
Yeah, well, it's great to see you, Udi, and we really enjoy having you be part of this course.